My name is Dr. Kendall Donaldson, and I'm a professor of clinical ophthalmology at the Bascom Palmer Eye Institute in Miami. I practice cornea, cataract surgery, refractive surgery, and ocular surface disease management here in Miami. So today what we're going to be talking about is optimizing your preoperative measurements and your phacoemulsification parameters for cataract surgery, so we can do our very best surgery each and every time we approach our cataract patients. I have a few disclosures listed here. So I wanted to start out with just a few preliminary questions to kind of gauge where we are at the beginning of this talk, and then at the end we'll come back around to these questions once again. So the first question, what percentage of cataract surgery patients have signs of ocular surface disease? We're going to give you 30 seconds here. A, less than 5%, B, 10 to 20%, C, 20 to 30%, D, 30 to 40%, or E, greater than 50% of patients. Okay, so kind of a mix there. Yeah, it's kind of, everyone said, let's see, most people said somewhere around 10 to 20%. Okay, let's go on to the next question. Which formula below can be most broadly applied to most eyes with cataract, undergoing cataract surgery? A, the Holiday, B, Hoffer, C, SRKT, D, Barrett, or E, Olson? Okay, looks like most people are using the SRKT and applying that to most eyes. Okay, let's go on. One more question. All of the following are screening tools for ocular surface disease before cataract surgery, except, and so A, we have tear osmolarity, B, phacometry, C, MMP9 assessment there, D, the Schirmer test, E, tear breakup time, or F, some sort of questionnaire, whether it be the most common ones are OSDI or the SPEED questionnaire. So all of these would be appropriate, except which is not an assessment of ocular surface disease. Okay, so again, a mix, but most people, 42% said phacometry. Okay, very good. So let's talk about making our very best preoperative measurements for cataract surgery. Some people sent in some questions beforehand, and so I kind of want to cater the talk to answering some of those questions throughout the talk. So I think nowadays patients really expect perfection from their cataract surgery. They all have friends or family members who have undergone cataract surgery, or they may have even had LASIK in the past. And we do kind of advertise to patients as well as to each other how great we are these days, that we can really provide patients the very best vision with cataract surgery. So we have to be very careful in what we advertise to our patients, though, because we still have some limitations. Although we've gotten better and better through the years, we really want to make sure we're managing patient expectations along the way as we do our surgery. So if we look at the typical benchmark standards for cataract surgery, we see that 55% of patients are within a half a diopter of the intended target, and 85% are within 1 diopter of the intended target. So that leaves about 15% of patients that are really outside of 1 diopter from our intended target. So there's still some room for improvement there. So how inaccurate are we? I think if we look at the most common formula, which is the SRK formula, you can see the variables in this formula. And these are the things that can actually go wrong. So whether it's, the Ks or the keratometry readings, the axial length, if we have an error in one of these variables, then that can really throw off our final IOL calculation for the patient. So you can see when we estimate corneal power, 1 diopter error in IOL power can occur for each diopter error in a K value. So we really want to be accurate with all of these measurements preoperatively to get our very best IOL calculations. So here are the 4 main sources of error. Ocular surface disease is really the #1 source of error, and it's also very common, we'll see shortly. And this can affect both the power of the lens as well as the axis. And a lot of times now we're doing toric IOLs, we're doing astigmatism correction with our cataract surgery. So either of these errors could be really devastating for a patient. We can have instrument error. A lot of our patients these days have had a history of RK, LASIK, PRK, and now we're doing their cataract surgery. We make some assumptions in all of these formulas, and they may be off because we've changed the shape of the cornea. We may be using the wrong formula. So we talked about the formulas. We'll go into that again in a moment. But if we use the wrong formula, we can be completely off with our IOL calculations. And then number 4, the index of refraction. This is being changed by any of our corneal refractive procedures. So we can have an error in the index of refraction, which would then be translated into an error in IOL calculations. So here are the formulas that we've used through the years, and they're kind of defined by the generation, where the 5th generation formulas are the most advanced, really take into account the most variables in calculating our IOL. So you can see the older generation, the Holiday, Hoffer, and SRKT have now been modified to the 4th generation formulas. The Holiday 2 has to be a purchased software system. The Hygus and then the 5th generation formulas can be applied to a broader group of eyes, the Olsen or the Barrett. The Wang-Koch adjustment is applied to several of these formulas for longer eyes, so highly myopic eyes with axial lengths greater than 26, you have to use this modification at the bottom. I really like this, this little illustration here. This is something that I borrowed from Warren Hill. And you can see all the different formulas here with the most advanced formulas at the bottom there, including the Barrett and the Hill. The Barrett 2 is actually the most advanced and most commonly used and is now being incorporated into most of our IOL masters, lens stars, and other forms of IOL calculating instruments. The Barrett Universal formula is really thought of as being the most advanced formula that's been the most well established and can be applied to most eyes most accurately. So how do we get our very best numbers for these formulas? There are lots of different ways to measure the corneal surface. We can see here just a bunch of different topographic and tomographic devices. We've kind of gone from topography, which is a 2-dimensional way to measure the cornea, now to 3-dimensional devices called tomographic or tomography devices, which give us that 3rd dimension in the cornea. So we really need to screen for potential complications before surgery, because any complications seen after surgery or error in IOL calculations seen after surgery is considered our fault, really, or a complication of the surgery, where it may have been a pre-existing condition that could have been missed. As I mentioned before, the #1 reason for IOL miscalculations is ocular surface disease. And dry eye is really everywhere. It's one of the most common things that we see in our general practice, but sometimes when we're completely focused on the cataract, we might overlook some of these other things that are going on in our patients. So this can be a debilitating condition for many patients, and it can really affect our outcomes. And it's really frustrating to us as surgeons when we have our perfect surgery, the patient's 20/20, and they feel that our surgery is a devastating failure because they're irritated or struggling with their dry eye more after surgery. So they would think that that's our fault if it were diagnosed for the first time after surgery. The International Dry Eye Workshop, or DEWS workshop, was originally convened in 2007, and they've helped us with the diagnosis and the management and treatment of dry eye disease. And they met again in 2017 to really define how we should treat dry eye disease, and this treatment should be started before cataract surgery, really to optimize our measurements. We can see from this great study, this was a landmark study called the Phaco study, that really looked at the incidence of dry eye in just cataract surgery consultations, patients presenting for cataract surgery consultations. So 60% of patients never complained of foreign body sensation. However, on exam, about 63% had an abnormal tear breakup time. And you can see here also that a large percentage of the patients, 77%, had some degree of corneal staining. And so they did have some ocular surface disease that was either asymptomatic or undiagnosed in just the routine cataract workup. So you can see 22%, or 1 in 5 of patients, had prior ocular surface disease. And a lot of these patients are asymptomatic, and sometimes the questionnaires, as I mentioned before, can be very helpful in teasing this out. But you can see here there's more than 60% had an abnormal tear breakup time. More than 50% had some central staining, and Schirmer scores were also abnormal in many of these patients. Here's another nice study by Preoperative, also looking at the incidence of ocular surface disease in our cataract pre-op patients. In this study, 57% had abnormal osmolarity and 40% had corneal staining. Again, signs of ocular surface disease before cataract surgery. And there's several other studies that have really documented this problem. We have lots of different ways to assess the ocular surface. I think, as long as you use 1 or 2 ways and you're consistent with all of your pre-op cataract patients, then that's what works for you in your clinic, but you should have some form of screening. I think questionnaires are really simple. A patient can do that in your waiting room, and that can be coupled with a Schirmer or osmolarity. In our office here, we use an OSDI, which is a questionnaire, as well as MMP9 and osmolarity. So we have 3 ways, and we do that for all of our pre-op patients. But not everyone wants to spend the money on some of those devices, so there's cheaper ways to do that listed here. But it begins with the actual exam on the patients. Certainly we see here the irregular fluorescein staining. I really still like 2-dimensional devices like we see here with the Placido imaging on the right. Those Placido rings are irregular, indicating ocular surface disease. There are lots of different symptoms that patients can manifest in many different ways with dry eye, which we see here. So we really have to ask, okay, so, the OSDI and SPEED questionnaires are the most common, very quick questionnaires to assess ocular surface disease. We really also have to take into account their medications and their other systemic conditions that can impact the ocular surface. And of course, our slit lamp examination with various forms of staining of the ocular surface that can all be ways to help us look at the signs of ocular surface disease. Okay, so pick one and be consistent with it. The Schirmer test, is a very simple way, not expensive, but it can help us really assess our patients preoperatively. We do tear osmolarity on all of our patients. Again, you have to invest in this device, but we find that there can be some irregularities with the results, so it works well, and when coupled with some of these other things, we use it along with the MMP9 and the OSDI. So there's this great study by Alice Epitropoulos that showed the effects of ocular surface disease or elevated tear osmolarity on both the power and the axis of our IOL calculations. So we can really see through this study that this can affect, non-treated dry eye can really affect the power calculations and our axis if we're doing toric or astigmatism management, which has become more and more popular through the years. I find that about 30% of my patients are asking for astigmatism management during their procedures. And in a lot of practices, that may be even higher. So there are many sources of error in our IOL calculations, but again, the #1 source of error is a poor tear film and dry eye syndrome. If your corneal topography does not look perfect, then reassess the tear film, treat the ocular surface, and bring the patient back at another visit for repeat topography and tomography. Not every technician is great at this, so I have a few technicians that do all of our ocular surface measurements, that do all of my IOL measurements. Make sure the patient doesn't get drops or they're not dilated before they get their measurements. So when do we repeat measurements? Anytime there's an inconsistency, if they're very steep eyes, very flat eyes. If we see a difference in the corneal power, the eyes should be pretty symmetric. So anytime there's an asymmetry between the eyes, we want to repeat those measurements and make sure that that's correct and accurate. Anytime the patient has high astigmatism, I like to repeat it. Again, small or large eyes. You can see here on the right-hand side some areas of hot spots. Okay, that's an abnormality. That should be repeated and verified to see if it's ocular surface disease. Is that a Salzmann nodule? Does the patient have anterior basement membrane dystrophy? So we want to make sure those things are treated. Again, we see that here. This is topography. We can see the Placido rings, which are irregular. Those rings should be nice and round. Those irregularities indicate pathology. We also have some lid obstruction here. Again, we see the hot spots, which are abnormal. Should be treated. Sometimes that may even require a superficial keratectomy for a Salzmann nodule. When I do that, which I do all the time now, it seems, I do the procedure and then I bring them back a month later for repeat topography, tomography, and then I may do the IOL calculations at that time a month later after they've healed. We do mybomography on a lot of patients. We really pick up a lot of MGD before cataract surgery, and then we can treat that preoperatively. We also have to help patients identify the influential factors for their dry eye condition, whether they sit at a computer all day or other things listed here can really affect the ocular surface. So this is how we do our screening here in our office. Again, just be consistent, find a way that works in your practice and get your technicians on board so everyone's doing the same thing. So let's stop. This is that was the first thing I wanted to cover. And a few people sent in some questions beforehand. So I do have a few questions that we can answer here. So the first question that we had received, how can we measure the exact astigmatism for a toric IOL? The way I like to do it, I do both tomography and topography, and then we get an IOL master. The IOL master 700 is the most advanced, but I still think that the 500 gives us excellent data. So I match up all of those devices, and I like to see that those torque measurements are consistent with the patient's manifest refraction. If there's a big difference between the manifest and these other measurements that we're making for cataract surgery, then that's a sign that maybe either this patient needs some preoperative treatment for the ocular surface, or maybe we need to repeat the measurements. So we just got another question. How long do you treat MGD before proceeding with surgery? So if I diagnose MGD, I usually start treatment and I'll see the patient a few weeks later for measurements, and I'll look at the measurements at that time. And if the measurements if they look good at that time, we'll go forward. If I'm not happy with my measurements, I'll bring them back every 2 to 3 weeks. I find if I let them go too long, they feel that we're not actively working toward their cataract surgery. So I don't like to leave them too long. So I like to see them back 2 or 3 weeks later to make sure they know that we're working together toward this and they haven't just been left for 6 months. Another question was just written in, how long do you have to treat the ocular surface disease medically prior to repeating the measurements? Again, I'll do every 2 to 3 weeks. I like to check them again. If I do a superficial keratectomy for anterior basement membrane or for Salzmann nodules, then I see them a month later after a superficial keratectomy. Okay. And one other question that was sent in, how different can the topography measurements be from the manifest refraction before feeling uncomfortable about putting in a toric lens? So I like to see those measurements be within 10 degrees of each other. So I really want to see consistency between multiple measurements. We do both topography and tomography, and I look at the manifest to make sure those match. Not everyone has all of those different devices. I really like the Pentacam. It's a really nice device that shows us both phacometry, and it gives us 3 dimensions. It gives us Scheimpflug images. It also gives us Placido, so that's a really nice tool. I also use a Galilei. I really like the Ks on the Galilei, but if you had to buy just one device, the Pentacam does pretty much everything for you. Okay, so let's move on with the next section now. Okay, let me just get rid of this. Okay, so let's spend some time on this. This is what I wanted to spend the bulk of this presentation on. So we're going to talk about the phacoemulsification machine and how to really understand this. And I really think it's important to understand how our machines work in order to best set our parameters and how to do our surgery most effectively. So I think we need to understand what phacoemulsification is and where it came from. So actually, I think we all are aware that Dr. Charles Kelman came up with phacoemulsification in his dental office. And this was learned from the procedures of cavitation, similar to performing the removal of a cavity, with the implosion of microbubbles, creating waves of both heat and pressure, like a jackhammer type action there. So here are the 3 major principles of phacoemulsification. Number 1 is followability. We need to have a handpiece that's going to attract those fragments back to the tip as efficiently as possible. Then stroke length, that needle goes in and out of the tip of our phaco device, and so we can modify the stroke length, and that's based on the power settings on our machine to see how long we want that protrusion to come in and out. And then we want to make sure we use the minimal amount of power and energy to emulsify this nucleus. All surgery is trauma, and we want to make sure that we're performing the least amount of trauma to this patient as possible to reduce the heat, to reduce endothelial cell loss. I mean, there is a huge range in endothelial cell loss between poor surgery and great cataract surgery. So we'll learn a little bit about that through my talk today. So this is a wonderful book. If you don't have it or haven't seen it, I would definitely invest in it. Or you could take Barry Seibel's course. He offers it at most of the major meetings like ASCRS, AAO, but this is a wonderful course, or you can get the book. But he talks about all the principles of doing efficient cataract surgery. And I'm going to share a couple videos that I borrowed from Dr. Seibel. But he also explains how fluidics work to really create a balance of inflow and outflow so we can make sure the chamber is maintained and that we're performing efficient cataract surgery. So there are basically 2 components to phaco dynamics. One is fluidics, and 2 is the release of ultrasound or energy into the eye. So let's start with fluidics. So this is the basic phaco machine. All phaco machines are fluid-based, so we always have a fluid source, whether it be a bottle or some form of bag of fluid, an irrigation line that's taking fluid into the eye. The phaco machine allows us to pump this fluid through the eye, and this is coordinated through the use of a foot pedal. So in position 1, we're just irrigating. We have simply fluid. Position 2 on our foot pedal introduces vacuum. So now we're able to suck fragments into our waist area. And then position 3 adds ultrasound. So then we're adding a phaco power to actually break up the material in the eye. So this is the basic phaco machine there. And here's our foot pedal again. I mentioned the 3 positions. We want to make sure that we're going to be efficient, not going into position 3 until we really need it, okay? So we don't want to release any ultrasound unless we should be in position 3. So we want to use that position the least amount possible. So fluidics, as I mentioned, cataract surgery is all about the creation of balance. So the fluid in has to equal the fluid out to maintain the space, to keep the anterior chamber inflated, because if we collapse the anterior chamber at any time, we're going to kill endothelial cells, do iris damage, and prevent, and actually even cause vitreous prolapse if we don't maintain that space properly. We also want to create functional currents to bring those pieces to the phaco probe as efficiently as possible. And then we want to keep things cool, because if we produce thermal energy, we'll cause a wound burn, and we also kill more endothelial cells. So this pump creates the vacuum and the flow. There are 2 types of pumps. The most common type of pump, particularly here used in the United States, is peristaltic. And then the second more common one in Europe actually is Venturi. But most of our pumps in the Alcon phaco machine, which is probably what most of you use, the Infinity or the Centurion, those are peristaltic pumps. So let's talk about what a peristaltic pump is. So it's a fluid pump. The fluid is pumped through this tube, and if we think about peristalsis, you know, it works exactly like this, just like the intestines. So we have these rollers that pinch and compress the phacotubing, basically milking fluid through a tube, and then we have a drainage bag. So this is our most common peristaltic pump, and we can see here occlusion is required to grip any piece. So if we don't have full occlusion here, then we shouldn't be releasing energy. So I always tell my residents and fellows, don't ever go into position 3 until you have 100% occlusion, or you're wasting energy. You're putting extra energy into the eye. So just remember, occlusion is essential for all peristaltic pumps. So we can see here we have various tips that we can use, various angles. I find that the more angled tips are very helpful, because with getting occlusion, it allows us to really have full occlusion there at the tip. So it increases the surface area basically here for occlusion as we go to a 45-degree angle. So we can see here, it's hard to get occlusion with an angle like this. We get better occlusion right here. We've turned the material, the nuclear material a little bit, and we're meeting it with 100% occlusion. That's very effective. Okay, so again here, just emphasizing a non-occluded phaco tip. You shouldn't be in position 3, okay? You're releasing excess energy into the eye. So just make sure you're completely occluded, because then your vacuum goes up, you're sucking onto that piece effectively, and we can release our ultrasound most efficiently. In contrast to the peristaltic pump, with the Venturi pumps, again, more of the pumps that we see in Europe, okay? So this is based on compressed nitrogen flowing over a rigid drainage cassette, as opposed to a bag, which we had, a non-rigid cassette with the peristaltic pump. This creates vacuum as it goes from a high pressure to a low pressure system here, and the vacuum helps us suck those pieces to the phaco tip. Here you can see a non-occluded phaco tip. The vacuum is still high, so the followability is actually very good. With an occluded phaco tip, again, the vacuum stays high, but the fluid can't get in, so the fluid is lower. So as opposed to the fluid pump, which we saw with the peristaltic system, now we see this is vacuum dependent. So here's just a little table that helps compare the 2 pumps, the peristaltic, which is flow-based, versus the Venturi pump, the nitrogen-based vacuum system. Okay, remember the peristaltic pump vacuum is created only on occlusion. okay? Whereas the vacuum is created instantly and constantly with the Venturi pump, okay? Again, with the peristaltic pump, the flow is constant, and until you get occlusion, then the flow stops and we're able to suck into our machine, okay? And so those are the major differences. I just want to go briefly into tubing size and tip size. So you can see the flow is directly dependent on the radius of our tubing here to the fourth power, okay? And also the pressure gradient, which can be created through how high your bag is. So let's go into that. So we can see that the flow is increased as the phaco needle tip diameter is larger. So if we have a larger diameter tip, then the flow can be higher. Makes sense. Okay, and we can see here, again, we get higher flows with larger tips. But we have to watch out for surge, and surge can be horrible. That's when you have a sudden collapse of the anterior chamber. If the outflow is greater than the inflow, then we can't keep our anterior chamber inflated, and we could cause damage, and we have a risk of capsular rupture. I'm going to show you a video of this, so this is actually a video that I got from Barry Seibel, who is the author of Phacoemulsification. He's a wonderful cataract surgeon, but you know, and I could show you this entire surgery, which is really terrific. He's a great phaco chop surgeon. We can skip ahead just a little bit, but and I'll show you a better example of phacoemulsification shortly. But you can see here he's doing his capsulorhexis, nice round capsulorhexis there that he's pulling around with Utrata forceps. And then he has this nice hydrodissection cannula here that's curved. I actually use a straight one, but you can see he's able to reach out toward the periphery of his capsular bag and really hydrodissect nicely and rotate that nucleus really nicely within the capsular bag, making the rest of the surgery much easier. So we have to remember every step in cataract surgery is dependent on the preceding step. Having that perfect wound, you know, making sure that you're even comfortable sitting there the whole time. And it took me a while in practice to understand that my comfort and my positioning, making sure that I was going to be comfortable, really made the whole surgery better for me. So every step is really dependent on the preceding step. So we'll see here. Now already I saw a little bit of instability in his chamber when he just went in there. And this is a little bit older video, but we'll see here he's putting in his second instrument. So he uses a Seibel chopper. So you can see it's similar to a Nagahara, but it has a curved tip on the end, which is really beautiful. If you're an early chopper, this is really the way to go with this device. You see the rounded tip, so you can't break through the posterior capsule. It can just glide over the posterior capsule. And you see how Barry reaches out to the periphery of his capsular bag, getting underneath his capsule edge. So make sure you can visualize the capsule edge. I think if you're first starting with chopping, it's nice to stain your capsule. Use some trypan blue to stain the capsule, I'd say, for the first 10 cases, just so you can make sure you get under that capsular edge. And I'm going to show you a couple of really nice videos of chopping. But again, this is a wonderful instrument to do early chopping with. He gets out there and you know, to the periphery, and he's able to bring the chopper right into the tip of the phaco instrument. Again, don't reach with the phaco probe at all. He's keeping his phaco probe very central. And so that's really important to make sure you have safe surgery. When my residents or fellows start reaching that phaco probe out to the periphery, I start to get nervous, and that's not safe surgery. So if you have to reach with something, you reach with your second instrument. Don't reach with the phaco probe itself. Okay, the second instrument can bring your materials. You'll see he's kind of reaching around, and he's just chopping again and again. You know, the more chops you can put in there, the less energy you'll need to really manipulate those pieces. But you can use your second instrument to bring the material. And look how his anterior chamber is very unstable now, okay? So you can see, look, you'll see the iris kind of going down. So here is surge. This is a perfect example of surge. Watch how the anterior chamber kind of collapses at times here. See, the iris is going in and out. This is dangerous at this point. So he should have kind of stopped. Why is my iris going in and out? Why is my anterior chamber collapsing at times here? So what's happening here is the sleeve is not the right size for his phaco tip. Okay, so you have to figure out what's going on. Is my wound too big? Do I have fluid leakage through the wound? is my sleeve the wrong size sleeve for this phaco tip? But this is getting very dangerous now, especially as he's removed several pieces. So the pieces aren't supporting the posterior capsule anymore. So this is when problems occur. This is when posterior capsular rupture occurs. When you have very few pieces left in the eye, you have no support now for the posterior capsule. And these last couple pieces, this posterior capsule is going to fly up. His anterior chamber is going to collapse, and he could have a posterior capsular rupture here. So this is a very unstable way to perform cataract surgery. So a nice bad example here, although we had some good examples of phaco chop. We should have stopped and figured out what was the problem with this case. Okay, let's move on. So that's a great video. It really illustrated a lot of great points of phacoemulsification, what to do and what not to do. So the problem of surge, again, we don't have the balance of inflow and outflow, okay? So the inflow is based on how high your bottle is, okay? And that you have two sources of outflow. You can have loss of fluid through your incision. Again, as I mentioned, look at your incision. If you have a bad incision, it's too big, you're getting leakage, that will cause an unstable anterior chamber. Okay, so keep inflow greater than outflow to maintain your anterior chamber volume. So briefly, let's talk about the physics of the tubing. Okay, so you can see here, inflow tubing and outflow tubing are different. Let me just show you a little bit about this. I'm going to go back to that slide in just a second. But occlusion of the tube happens here, and compliant tubing can collapse, and that will store energy. And then post-occlusion surge occurs when this tubing rebounds suddenly. Okay, so that's how surge happens. And so we can see here, this is the difference between inflow tubing, which is much larger diameter, it's a soft tube, and outflow tubing, which is a rigid tube, has very low compliance. And this is how all phaco machines basically work. Different companies talk about various advances in their tubing, but this is basically how they all work. So we can see here the inflow tubing versus the outflow tubing, and this helps create a stable anterior segment for cataract surgery. So enough about that. Everyone's trying to make their incisions as small as possible. So this is the difference between coaxial versus bimanual irrigation. We've been going toward the size of smaller incisions, but when we have smaller incisions, as I mentioned, the tip sizes of everything and the tubing sizes are much smaller, so the flow is slower. So everything happens a little bit more slowly. There are a lot of advantages to the split irrigation instead of coaxial. I like to use a bimanual like this when I'm removing pieces from underneath of the wound, that last spot where you can really get some sticky cortex underneath the wound. So bimanual is really helpful in that kind of situation. I also like bimanual for femto cases because they have very sticky cortex, so I find I get better control with the bimanual irrigation. I actually use the transformer device from Alcon, which allows us to use either coaxial or bimanual. So it allows us to switch back and forth as needed, and there are some benefits to each. So again, as I mentioned, with the small incision surgery, it's great to have small incisions, but everything moves much more slowly. So we went through the issues with the tubing size. This is dependent on tubing size. The smaller our incisions, the smaller the tubing, the slower the flow. And we explained that before with this equation. So again, we see the radius and the diameter basically are directly proportional to flow in the fourth power, and again, the height of the bottle. So a high pressure gradient, if we elevate our bottle very, very high, we have a forceful entry of fluid into the eye. So we don't want this to be a forceful jet of fluid like a fire hose, so we have to modulate this. So again, we can raise the inflow within reason. We can raise the bottle, but we want to keep it at a reasonable height. If we go too high, then it increases the pressure of the fluid into the eye. Okay, so always keep inflow greater than outflow. Nice tight incisions are helpful. We have the restrictive outflow tubing. So let's go through the phaco machines. I think the Alcon Infinity or the Centurion are the most common ones used, kind of have the market share in most of the world, although there's also the Johnson & Johnson Signature and the Bausch & Lomb Stellaris, also great instruments and more common in Europe, I would say. So the Alcon Fluidic innovations, we have here both the Infinity and the Centurion. I use the Centurion at this point in time, but I think a lot of people still are using Infinities, and those are great machines. So we'll go through some of the advances and differences there are between the Infinity and the Centurion. Again, we talked about peristaltic systems. It's really important to have a completely occluded phacotip that's entirely dependent on the occlusion of the phacotip. And here, that helps eliminate the post-occlusion surge also. Alcon's done great things with their tubing. And this is the difference with the Centurion. No longer is there a bag. We actually set the pressure, the IOP, at a certain level, so we don't have to raise or lower the bag. So most people set their IOP somewhere between 40 and 65 is pretty typical. And the pressure will be maintained at that level throughout your case, as opposed to having to elevate the bag to different levels. And the interchamber is very, very stable throughout the whole case. So that's really been the biggest advance with the Centurion. So active fluidics, again, the surgeon selects the target pressure to be maintained throughout the procedure. You set your irrigation level, and you know your leakage flow rate as long as your incision is tight. So you set these three things, and it keeps your anterior chamber very, very stable throughout. They've also introduced a new tip called the balanced tip. It has both torsional as well as longitudinal phaco released. And it has the 45-degree, we talked about the angles of the tips, and it swings back and forth to help introduce that torsional component, really to make the ultrasound release much more efficient. Okay, that's what we see here. So when we switched from the Infinity to the Centurion, we actually saw a 38% reduction in our energy dissipated during phacoemulsification. So there have been several studies that have also showed that same reduction in energy usage with the active fluidics. Johnson & Johnson has both the Sovereign and the more recent White Star fluidic innovations. They basically have a device, they call it case or chamber stabilization environment. And basically what this does is it is software that helps anticipate the occlusion break, and it proactively just drops the vacuum level so that you can help eliminate surge. So you can see here when the occlusion breaks, then the vacuum goes down. That's when you would get surge, but through the case system, it cuts that in half. So you don't get as much of an instant drop in the vacuum to help make that more safer. And the system is very nice because you have both the peristaltic and the Venturi options. Sometimes the Venturi can be very helpful. The followability is really wonderful with the Venturi system. And so a lot of surgeons like this ability to go back and forth between the two types of systems. This is their phaco tip. Again, most of the tips are now able to have both transverse and longitudinal modalities to try to improve efficiency of just breaking up that piece of the cataract material. And this is the B&L Millennium and the Stellaris. Again, they really advertise their restrictive outflow tubing. Every company has their own tubing, but this, again, helps to prevent surge, create a stable anterior chamber, again, keeping the inflow greater than the outflow. The key thing is being efficient. They have both the peristaltic and the Venturi systems, and it allows both coaxial and biaxial ways to perform your irrigation aspiration. So then there are ways to modulate the release of energy. And I wanted to spend a little time talking about ultrasound energy. So this is the main source of trauma during cataract surgery. So this is where we're introducing the energy, and the length of the stroke creates the mechanical impact into the nuclear material by cavitation, as we mentioned before, but also creates heat as a side effect. Okay, so we can set several variables. We can set the frequency of the impact and the length of the stroke, and then the movement of the tip basically while delivering that stroke. So this again is cavitation, again, similar to dentistry, as we mentioned, that Dr. Kelman had noticed originally. But it's basically like a jackhammer effect. We're releasing energy into the eye, and we want to release the least amount of energy, use the least amount of ultrasound possible. We can burn the cornea in seconds. You know, fortunately, with all these innovations, wound burns are very uncommon these days, but still in a very dense cataract, this could happen. So we want to make sure we have good flow, and we want to make sure we maintain our anterior chamber and use the lowest power settings that we can to get rid of this cataract. So we want to make sure that we can decrease our phaco time. Okay, basically that's our goal. This will cause less trauma to the corneal endothelium, minimize endothelial cell loss, and prevent pseudophakic bullous keratopathy, giving the patient the best vision as quickly as possible after cataract surgery, which is what patients expect these days. They really want to see well right away. Okay, so patients want their cornea to be clear as early as post-op day 1. And I find in some of my denser cataracts where I can anticipate that the cornea is not going to be clear the first day, I try to tell them that ahead of time. You know, that your vision's going to be blurry for a few days. This is a special type of cataract surgery that we're doing. You know, maybe we're doing pupil stretching, sneakulolysis, 4+, you know, hypermature cataract. But if I can anticipate that the vision's not going to be good or it's going to be a delayed healing, I would like to tell patients that ahead of time. So again, we want to keep our phaco time down as low as possible and protect the corneal endothelium. Lots of good quality viscoelastic is really key, and again, decreasing phaco time. So what are the components of absolute phaco time? We said we want to keep this as low as possible. This is a measurement of the total phaco energy delivered to the eye during our surgery. And so we can see it's a combination of the time that we're releasing the energy into the eye and the power. So we want to decrease both the time and the power that we're releasing this energy. And so we can see, you know, we can have a very short time that we release phaco power at high power, and we still end up with 15 seconds of phaco time, absolute phaco time, or we can have a very long time in the eye, you know, at a very low power, and we still end up with the same amount of ultimate energy in the eye. So again, we want to decrease the absolute phaco time by decreasing both these things ideally. Okay, so how do we do this? So there are lots of keys to doing this: a mechanical nucleus disassembly, using chop techniques instead of grooving a lot. Every time we groove, we're releasing energy into the eye. So, you know, divide and conquer is great. It's certainly a great way to be starting out, a very safe way to start out. But as we progress on to more advanced techniques, stop and chop is really nice with a central groove. I'll show you a video of this. And then using chop for the remainder. That's a great transition from divide and conquer to stop and chop. And I don't do one-handed phaco, and I don't recommend it. I think it's unsafe, but there's certainly some people that are excellent at it. But I think most people do two-handed phaco, and it's nice to have a second instrument to protect that posterior capsule and help bring the nuclear material to the phaco tip. As I mentioned, ideally, we want to keep that phaco tip in the center of the eye as much as possible and do all our manipulation with the second instrument.
Hello, my name is Brian Kim, and I'd like to share with...
Before this starts, I just wanted to acknowledge David Chang here. His picture's up in the upper right-hand corner, but he was the originator of Phaco Chop. But I really love this video by Brian Kim, which I think is really one of the best videos of Phaco Chop that I've ever seen. So I wanted to share this with you. And Brian does narrate this, so let's just let him show you this.
You an in-depth, step-by-step explanation of how I place my chopper and phaco tip during my phaco chop technique. This is a schematic of the eye. The pink is the phaco tip and the chopper is in black. As you can see, the phaco tip is placed sub-incisionally within the anterior capsular opening. The tip is slid down into the epinuclear material, but outside and around the endonucleus and holding the endonucleus at the same level. The chopper is placed at the same position on the contralateral side. This is the Alcon balance tip. This is a proposition, but I flip it 180 degrees so that it's beveled down. And you can see when it's beveled down, there's actually a little bit of a curvature to the phaco tip. And I use that curvature as the part that actually touches the lens as I fracture it, pushing it.
Most people don't do that bevel down. Okay, so that's the only thing comment I would make there. Okay, everything else I think is wonderful. That's a little tricky, and you're at higher risk for a posterior capsular rupture, so I wouldn't go bevel down. I'd use it the regular way.
Forward. This is the proper position of the chopper. When I go into the eye, you want to stay in the pronated position with your wrist, and then you supinate your hand so that the chopper tip is facing you when you initiate the chop. So again, pronation, supination. I like to go in the eye, pronated, and just to show you, I'm going in with one hand. I'm sliding the chopper in the pronated position down into the epinuclear material underneath the anterior capsule, rotating my hand so that it's supinated now. This is the ready position for the chop maneuver. Just for illustration, I'm going back out, pronated, and then supinated back into the equator, and I'm in the ready position to initiate the chop. The phaco tip, again, it's within the anterior capsular opening, and I dive down into the epinuclear material, but I know that I'm outside of the endonucleus, but at the same level. I'm bringing the two instruments together in the center, and the chop is initiated without difficulty. The cross chop, the same maneuver of pronating and supinating the wrist, and then bringing the chopper into the middle and fracturing. This is another.
Just to comment, only because there was a question written in about the settings on the phaco machine for chopping. So you can see his vacuum is very high, so he can really get occlusion of the material when chopping. So that's super high. I usually use about 575 for vacuum. And when you're doing chopping, I would also recommend a burst technique. So that really helps you get good occlusion so that you can then hold on to the piece as you're bringing your second instrument in to the phaco tip, okay? So high levels of vacuum and burst for chop mode will help you get good purchase on the nuclear material so then you can do all your work with the second instrument.
For example, again, I'm in the pronated position, going into the eye, sliding under the epinuclear material, rotating my hand. You see I'm nudging the lens just to prove to you that I am indeed in the equator. Because I'm in the equator, when I do that maneuver, the lens jiggles, the lens moves within the horizontal plane. If I'm on top of the lens, as I'm showing here, when I try to supinate my hand, all it does is cause the lens to tiddlywink, and it doesn't actually move horizontally. Again, I'm pronated my hand, I went out underneath the anterior capsule to the equator, and then I supinated. I'm going to do that again. After I clean up this epinuclear material with the phaco, again, pronated, slide it past the anterior capsule, supinated, the chopper tip again within the anterior.
Okay, so let's move on in the interest of time. So how to decrease phaco time energy, less time on the foot pedal. Again, avoid position 3 unless you really need ultrasound, okay? Let's move on here. So decrease our power settings. How can we decrease our power settings? Well, fortunately, all of the companies have developed an advanced power modulation software. So we can have times when we're not releasing any energy, and the energy can be released in packets like this. Okay, so again, we want to keep our phaco tip as cool as possible, release the least amount of energy. And each surgeon can customize this, and all of the companies are willing to come out and help you customize your parameters. So we can see the difference between continuous phacoemulsification. As you press down on the foot pedal, the energy increases. With pulse, you can see these packets of energy being released with breaks between each package. And as you push down on the foot pedal, you get increasing amounts of energy. And then burst is an equal amount of energy released at intervals. Okay, so that's the difference between pulse and burst. Okay, so here's phaco continuous. Okay, again, constant energy delivery. Here's pulse, again, going up, ramping up, but little breaks between. And then burst, all the same amount of energy each time, but having intervals in between. So all of these can be set and really customized, and I would encourage you to have your representative from whatever company it is come out and help you make your settings and optimize your settings for you, okay? So you can have these hyper settings, which are advanced, you know, the pulse modes, up to 120 pulses per second. So in burst mode, your duration as low as 4 milliseconds. You can set your duty cycle, how long it's going to be on versus off. And then there's some pulse shaping I'm going to show you in a second. So here again, we're conserving energy by having some packages where we're releasing energy and at times when we're not releasing energy. And that can be really modified per each individual surgeon. Okay, so you can see here also, you don't magically decrease the phaco time. We can have the same amount of phaco time here. Here we have a large delivery of energy only twice, but that's equivalent to all these small packages delivered more frequently. So yeah, so that just kind of explains the same thing that I just mentioned. So this is all dependent on the duty cycle. So you program how much time you want the energy on versus how much time you want the energy off, okay? And these are examples of variable duty cycles, again, just customizing it for each individual surgeon, trying to reduce the amount of energy delivered to the eye. So this is an example, on 20%, off 80%, or 20% duty cycle. Okay, and the benefits, again, we're reducing energy placed into the eye. And this is just some more examples on different ways that your duty cycle can be arranged for you. Okay. You can also do pulse shaping where you can have a ramp up. Again, another way to reduce energy. So here we'll reduce this amount of energy here. So that can also help with your efficiency. Any way to, here using a pulse pattern and cooling between, you can change the off times between there. Okay, so these are just other ways to reduce the amount of energy. Again, customizing it for what works best for you is really key, but getting best purchase, especially if you're a chop surgeon, you want to use some burst or pulse, but usually burst to really hold on to that piece to allow yourself to pull into the phaco hand piece. Okay, so we want to reduce the repulsive effects. So that's one of the advantages of the variable rise time. And also that's why I use burst to kind of get in and embed into the piece before I just use a bunch of power, which is going to push away my nuclear piece. Okay. So this is more just explaining what I mentioned. Again, you want to customize or tailor fit those to what works best for you. And the reps can help you try a few of these different things to really decide, okay, if you want to add some burst to help with chopping, that can be helpful. Okay. So let's look at a couple examples here. Okay. This is just a very basic, nice starting point for basic divide and conquer technique with cataract surgery. So this is a great starting point. He's got a nice wound. He nicked the capsule and now performing a nice round capsulorhexis. It's all about your view and, again, your comfort as well. So take time to find how you like to be positioned. Use your lighting so you can see the capsule properly. Fiddle with your lighting at a time when you don't have a patient there, so you can see how you can use a better lighting at different angles for the red reflex to be improved, so you can really visualize your capsulorhexis, because if you can't see, you can't perform adequate, safe surgery. So perfect capsulotomy. As I mentioned before, every step is dependent on the step before. Nice hydrodissection where you see that nice fluid wave behind the nuclear material. And here again, this is a basic divide and conquer. So we see a nice groove. And again, he's using a Cybele chopper here, even though he's doing divide and conquer. A lot of people will start with a Drysdale because it's flat and is useful for soft lenses. But I think this is a really nice, the Cybele chopper is just a really nice tool, and you can do both divide and conquer and chop maneuvers with this. So you had a beautiful crack there, and it's just going to safely, rotate. You can use both instruments to rotate. Sometimes if I have really loose zonules, I'll use the two instruments together and really kind of use them to help avoid torque on the lens there. So again, you can see he's got the two instruments pushing apart from each other, got a nice crack. Of course, it doesn't always work this easily, but this is the perfect patient and the perfect divide and conquer example here. So really taking his time, pushing out with the second instrument at the periphery to rotate that really nicely. And again, we saw that he had beautiful hydrodissection here, so the nucleus just rotates real nicely. And again, putting both instruments across from each other to separate. And then, so now it's easy. Of course, sometimes you can run across a posterior plate or things like that. So that's our basic technique. Okay, so let's go on to the next. So this is David Chang.
This is Dr. David Chang with an instructional tape on phaco chop. Now, the classic Nagahara method of phaco chop begins by inserting the chopper out peripherally beneath the anterior capsule, or I will hook the equator after having impaled it centrally with the phaco tip here in burst mode. See the two bursts. Once I hook the equator, you chop right toward the tip, and with a slight separation, this fractures the nucleus completely in half, bisecting it without the use of any sculpting. After rotating the nucleus for a few clock hours, the second chop now creates a pie-shaped segment that here I'm tumbling out using the Lieberman microfinger tip. The most difficult step is certainly the first chop, and the most difficult piece to remove is the first piece. Once this has been done, each subsequent piece becomes easier to chop and to remove because the condition, it has a very loose zonule complex. Of course, this is something that is a common problem with exfoliation trauma. You can see that I'm unable to rotate the nucleus. You can see how loose the zonules are. This is apparent as I attempt to rotate it with a hydrodissection cannula. In this case, the capsular bag is so poorly anchored that it actually just wants to rotate with the nucleus. So now what do we do? Well, one advantage of the microfinger, again, is the versatility of its placement. So a nucleus that I cannot rotate, it's fairly firm, as you can see here. There's the compression, the initial chop in half without any sculpting at all. And now what I'm going to do is simply cross over a few clock hours to the side and chop again. So although the phaco tip can't be really placed in multiple different positions, the microfinger from the side port can.
Okay, so let's move on in the interest of time here. This is just a quick example of stop and chop. Okay, so with stop and chop, we have a central groove. So this is a nice transition from divide and conquer to chopping. This is a Nagahara, which I think is safer than that microfinger you just saw David use, but the microfinger works great in his hands. I really like the Nagahara, but again, you're turning the tip to the Nagahara to the side to go under the capsule and reaching out. This one's kind of sticky, but still getting it. Let's turn it around here a little bit and hang on one sec. Again, doing all the manipulation with that second instrument, not with the phaco probe. And then using the second instrument to kind of feed that piece into the phaco tip. So you have a central groove and then using the second instrument to do the chopping from there out. Again, high burst mode, pretty high vacuum, 575, and reaching around with the Nagahara. The more chopping you can do, the better, the less energy you're putting into the eye. So, you can chop as many times as you want to get those pieces as small as possible. Let's go on a little bit more here. Let's skip this as another stop and chop example. So we'll skip that one. I want to show you what not to do. So this is a resident case. This is one of his first phacos, and he's using a Drysdale, which is one of the first instruments. He kind of just was pushing things around. I really think the spatulas like the Coke spatula or the Drysdale that are flat are really nice for an upside down chop, which I'll sometimes do, or with a very soft lens. But here, it wasn't too helpful. In this case, went on 2.5 hours. And you can see the longer you're in the eye, the smaller the pupil gets. And of course, he had some bleeding and that type of thing. But yeah, long cases are, I said, nothing really good happens in a cataract surgery after the first 10 minutes. So if you're in the eye for 2.5 hours, something bad is happening in there. But again, with the Drysdale in this case, he was just kind of pushing things around and not being effective. We can skip over my loop in the interest of time, but I find that in very dense lenses, a lot of times the my loop is helpful. I used Trypan in this case just for teaching purposes, so we could see how the my loop fits under the anterior capsule. We'll watch just a few seconds of this. We don't have to watch the whole thing. I don't know if you've seen my loop before, but it can be a very inexpensive way to help segment a nucleus. You want to get a nice hydro dissection there. This is the my loop device. Now it was bought by Zeiss. And we're slipping this ring, a nitinol ring, underneath the anterior capsule. You can see that the my loop is into the level of that black line, and it's sweeping underneath the nuclear material. It goes all the way across. You can barely see it here, but if you look very closely, you might be able to see it behind the nucleus. Yeah, it went all the way across, and then once it's gone all the way across in a sweep, you go back to the center, going back to the center there, and then always use a second instrument at this point. Otherwise, the my loop will drag the material into the anterior chamber. So we're going to use a second instrument, a Nagahara here, just to hold that nuclear material back. So it doesn't, as you close the loop, it doesn't drag material into the anterior chamber near the endothelium. Okay, so that's basically the principle of the my loop. And let's just move on. So to become a better phacosurgeon, chopping techniques using ways to disassemble the nucleus mechanically instead of with ultrasound. Use less time on the foot pedal, decrease your power settings, use these more advanced techniques that allow us to have times when we're off of energy release modes, and use the advanced power modulations. And Fluidics is all about balance, maintaining a stable environment to work. So to be an efficient surgeon, we need efficient fluidics, efficient phaco power, and that results in efficient surgery, clear corneas, and less traumatic surgery. So let's go back to the questions we started with, and let's see what everyone thinks at this point in time. So our first question, what percentage of cataract surgery patients have signs of ocular surface disease? So we read these before. Is it less than 5%, 10 to 20%, 20 to 30, 30 to 40, or E, greater than 50% of patients presenting for cataract surgery? Okay, so still they're saying 10 to 20%, but it really is greater than 50% have some form of ocular surface disease, and that's been shown in several studies now. Okay. Number two, which formula below can be most broadly applied to most eyes without any adjustments? Just yeah. So A, Holiday, B, Hoffer, C, SRKT, D, Barrett, or E, Olson. Okay, so Barrett increased a little bit, but SRKT is still the one that got the most there. It's actually the Barrett formula. We don't have to use any adjustments. It works well in long eyes, short eyes, and regular length eyes as well. And finally, the third question, all of the following are screening tools for ocular surface disease before cataract surgery. A, tear osmolarity, B, phacometry, C, MMP9, D, Schirmer test, E, tear breakup time, and F, various forms of questionnaires, most commonly the OSDI or the speed questionnaire. Perfect, so it's actually phacometry, so 69% of you got that one. Okay, perfect. So let's see, we had a couple additional questions that came in. So let's see. Do we need to take K readings with both manual and an optical keratometer? If taking both, which do we need to take into consideration? Honestly, I haven't done manual keratometry in a long time. I think it's become sort of a lost art. We still have a manual keratometer, and as long as your technician or you yourself do it consistently, and you use the same device all the time and you're good at it, I think that's a great device to use. I would still use another topographic or tomographic device as well and make sure they're consistent. So I think it's always good to have a couple different measurements. So yes, I should consider both, but I would use also a tomographer or a topographer along with your manual So another question was, how is low CDE directly related to high vacuum and flow in the active fluidics? So, the CDE is calculated by a formula, and that is determined by the vacuum, the phaco time that we talked about. So, CDE is important, and it does take into account all of those things that we're talking about here, the vacuum and the level of the amount of time that ultrasound is released. But CDE isn't the whole story, though. I mean, we want to keep our CDE down as low as possible, but, lots of other things are important. For example, the size of the anterior chamber, patients that are hyperopic, small eyes, just that space in the anterior chamber being smaller causes more trauma to the corneal endothelium. Using proper viscoelastic is important. Performing cataract surgery in the bag instead of doing all this in the anterior chamber. So proximity to the corneal endothelium is very important. So it's not all about CDE, but I do pay attention to CDE pretty closely, and I try to keep it as low as possible during my surgery. So is pulse mode effective in the Centurion? Which power modulation would you recommend? I think pulse mode is great. Again, I use it with the Centurion all the time. I don't like to release continuous phaco energy, so I think pulse is very important. So I would recommend both pulse and or burst. Any tips for removing the epinucleus? I'd say the biggest tip would be having a good hydrodissection. Again, as we mentioned before, each step is dependent on the one before it. So if I have trouble removing epinucleus and it's really sticky, sometimes I'll go back and I'll hydrodissect again just to loosen it up again. If I'm really having trouble getting it out, like I said, I use the transformer so I can switch. If I'm already into IA, then I'll switch and use by manual. If it's really epinucleus though, and I've already gone on to IA, sometimes I'll go back and use the phaco tip again and use my epinuclear setting on the phaco tip, or use a second instrument to kind of poke it in to the tip. Let's see. So another question was, if you are a chop surgeon, are there any benefits of the MyLoop over a chop? As much as I like the MyLoop, I find it takes me a little bit longer to use it. And I think if you're already a good chop surgeon, the MyLoop isn't that helpful in most cases. It's just an extra step. When I find the MyLoop to be most effective is in a really, really dense cataract. You know how some of those 4+ brunescent NS cataracts have a posterior plate? So in those cases, if you have really good hydrodissection and you can get the MyLoop around to the back of it, it'll get through that posterior plate really nicely. So I'd say that would be an advantage over just a regular chop. But I'd say in a routine cataract, if you're a chopping surgeon, the MyLoop doesn't have really much of an advantage. It's just a routine cataract. Okay. So there's a question about is the incision location of any significance? There are a lot of surgeons that will change their incision location based on the astigmatism that the patient has. I don't do that at all anymore. I used to try to do that, but then I'd find that I was uncomfortable operating in a position that I'm not used to. So now I much prefer to control my astigmatism with either limbal relaxing incisions or with a toric lens. My limbal relaxing incisions, I open 100% of them at the time of surgery because I find that I don't get enough effect if I don't open them, and I go to 90% depth with my limbal relaxing incisions. But no, I don't change my incision location because we had done a study a while ago that showed my surgeon-induced astigmatism is only 0.11. So it's so small anyway, and I don't want to move it too central because then I'm afraid I'll introduce some irregular astigmatism. So I don't like moving the wound. And what gradient system do we use for describing the opacification for the lens? We all sort of use the LOCS system, LOCS, and it's gone through several modifications through the years. The accuracy, if people really use the LOCS system properly, probably most of us don't, but within your practice, you can consistently use it the same way. But I think most of us aren't using the LOCS system, although that's the most up-to-date system. I think most of us aren't using it most accurately. All right, so I think that, let's see, one more question and then we'll wrap it up. In my opinion, will certain surgeons, why are certain surgeons still performing extracapsular cataract surgery instead of phacoemulsification? Well, perhaps they never became comfortable with phacoemulsification. I find even in the very densest cataracts, I still am able to do phacoemulsification 99.9% of the time. Although sometimes I cheat a little in some of those dense lenses. I will use the MyLoop. I will use the femto laser to help me. So I use some of those extra tools in really dense lenses. I haven't had to do an extra cap. I've probably one in the past year, but I think extra caps are pretty rare. Sometimes I'll use an extra cap in conjunction with a PK, doing an open sky extra cap in a really, really dense lens when I can't see into the eye at all. So that'll be the last question. And I really appreciate you all joining today. And I hope this was helpful for everyone. And thanks to Dr. Barry Seibel and Uday Devgan, who helped me with some of these slides today and some of the videos. Thank you very much.